So now we are in a very good position to understand what and how diabetes can be diagnosed. Well, the question for you guys is, can random blood sugar be useful for diagnosis of diabetes? Then the answer is a big yes. You see, if a person is having presence of symptoms, that is polyuria, because sugar is very high in the blood, it will get filtered via the blood into the kidney and then it will draw water. So there would be an osmotic diuresis causing polyuria. The person will also be therefore drinking more water, so there would be polydipsia. And because diabetes is a catabolic process going on in the body, there would be development of a weight loss. So the third point that I put up here is not polyphagia, because polyphagia is not a classic symptom, as I explained to you. And along with this, if the random blood sugar of somebody is more than 200, we can say that yes, the person is having diabetes mellitus. But nowadays, he says, why should we wait for somebody to become symptomatic? Even if somebody is asymptomatic, like this person, he came to me, he's 45 years of age, and he says, the doctor, my father was a diabetic and I want to know whether I am having diabetes or not. So in an asymptomatic individual, I can be checking a fasting plasma glucose. Plasma glucose is always superior as compared to blood glucose. If the fasting values are more than 126, and the 2-hour values of the patient are turning out to be more than 200, I'll tell this person that already you are having diabetes mellitus and you need to take treatment. Then another possibility is that the patient refused to get that 2-hour plasma glucose value tested, because he says, tomorrow, like I have an important official meeting, I cannot wait in your lab for 2 hours, and why should I get pricked twice? So genuine question, right? Patient came today evening. Before coming to me, he had a dark Belgian chocolate pastry. He had a barista coffee as well. He's asking me, I just had a coffee and I had a pastry in the coffee shop, and now I've come to you for diagnosis of diabetes because I'm feeling guilty of treating that pastry. So am I having diabetes? So I can do a test by the name of HbA1c. You know that HbA1c is not affected by recent food intake, because it gives an average estimated value for the previous 8 to 12 weeks. So if the value turns out to be more than 6.5%, it is a diagnosis of diabetes. You can see that is in this entire table, there is no mention of the word postprandial. Postprandial is useful for follow-up of a patient. It is not useful for diagnosis. So I've just put a line to say postprandial value is not useful for diagnosis of diabetes. It is for follow-up of a case. Then as far as diabetic ketoacidosis is concerned, the D, K and A values I've already said. So I'll just make you revise this again, that for here the cutoff for random blood sugar to be taken for diabetic ketoacidosis is 250 and not 200. Then there should be demonstration of either ketonemia or ketonuria. For ketonemia, we can do a blood test by the name of plasma beta hydroxybutyrate. Ketonuria would be like urine ketostics 4+, and then acidosis would be bicarbonate less than 15, or if this is not given, pH less than 7.3. So diabetic ketoacidosis point I've explained already, but like what he will do in the question is he will mention that patient is in circulatory failure. How will he mention circulatory failure? He will say patient's pulse is thready, or crashing pulse, crashing blood pressure, whatever. Like the point is, if a person's blood pressure is unrecordable, then we first need to make it recordable by giving a normal saline bolus to the patient. You will appreciate this fact that earlier I was saying that we need to give a normal saline drip to the patient with KCL. I will be doing that also, but before I give a drip, I need to make the BP recordable. So he will say, what is the first line intervention in a patient? If there's a circulatory failure given, I will answer normal saline bolus, and after the bolus, the pulse will at least become palpable. Then I will give a normal saline infusion along with KCL, and after 1 hour of that, I will give insulin drip to the patient. So the treatment that I taught you earlier is valid even now, but immediately, like what I need to do for any patient with a crashing blood pressure is to give a normal saline bolus. Also, I would like to mention that there might be certain questions in which ABG report itself may not be given. You see, you cannot make a diagnosis of diabetic ketoacidosis without having ABG report. So when you will go through some questions in various apps, you will notice that the first question will be that D value will be there, ketonemia will be there. There will be no ABG. And then he will immediately say, what is the first step? Normal saline will also be given and ABG will also be given. First, you need to make a diagnosis. And then subsequently, you need to give a normal saline infusion to a patient. I repeat that again. Suppose in any question, if this data that I've just written here before you, if the ABG report is not given, then I cannot make a diagnosis of diabetic ketoacidosis, no? I mean, for DKA to be present, I need to say that A value has to be given in a question. If it is not given, then first do ABG, then give normal saline to a patient. So a large number of these questions will just try to, bluff their way by saying what is first step to be done. Don't jump into the answer of normal saline. Take a hard look at the question. What is the hard look? Is the ABG report given? If not, answer ABG. Suppose ABG report is given, then check the BP. If BP is unrecordable, give normal saline bolus. If BP is recordable, then the standard data. I've already told you, normal saline infusion with KCL followed by insulin drip to the patient. So if there is a dehydration, then yes, I mean, if he says what is the first line management in evidence of dehydration, tachycardia, low BP, not unrecordable, low BP, it is normal saline or ringer lactate would be given. Then check potassium. If potassium values are less than 3.3, then I will not give insulin drip. You see, potassium goes inside the cells when you give insulin. So you will worsen the hypokalemia of the patient. Insulin causes not only sugar to go into the cells. Insulin causes not only sugar to go into the cells, but it also causes potassium to go into the cells. So it will worsen the pre-existing hypokalemia present in the patient. Soda bicarbonate is not routinely used. Only if the pH of the patient is like, I can say less than 6.9, outrageous low values, that we might be using soda bicarbonate. Soda bicarbonate is not routinely used. The only if, in fact, I'll just hide, this is very extreme, guys. Again, you know, sometimes in the app, they're making it very extreme in questions, that they are mentioning pH of the patient to be extremely low. 6.9 usually in the survival of the patient will be very, very difficult. But still, for the sake of MCQ, I want to highlight two things. In fact, three things at the moment. Large number of questions may not be having ABG report given, answer ABG. If BP is unrecordable, give normal saline bolus to the patient. Soda bicarbonate is only if, the word is only if the pH of the patient turns out to be equal to or less than 6.9. And the last aspect is, why do these patients die? Well, the reason for this, don't answer dehydration. Obviously, it will be present. Don't answer hypokalemia, paralytic ileus. It will be present. The leading cause of death in these patients would be answered by you as, like, the first primary reason would be cerebral edema. Yes, guys, one of the primary reasons is that the protons cause damage to the blood-brain barrier. Because the protons are damaging the blood-brain barrier, therefore vasogenic cerebral edema will occur in these patients. The leading cause of diabetic ketoacidosis in children, I mean, obviously DK is more common in children, so I've not written the word children, would be answered as cerebral edema. So here I've tried to sensitize you to, again, certain common errors in the management. One of the most silliest question will be where ABG report will be not given, you will answer ABG, and the silly question would be crashing of blood pressure. So I've emphasized them again and again because people tend to straight away answer NS with the KCL for 1 hour followed by insulin. So you just need to keep a watch. Now I'll talk about unconscious, unresponsive diabetic patient. If he mentions, suppose, like he says the pH is 7.3, the PCO2 of the patient is 30, bicarbonate is 15. If all the three arrows are going down, 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 that means that person is having metabolic acidosis. I've explained the ABG section in the respiratory part, but if all three arrows values go down, bicarbonate is low, it's metabolic acidosis. He says urine ketones of the patient are 4+, and the random blood sugar of the patient is 300. Then this is a case of diabetic ketoacidosis. A special investigation that I can order if facility is available is beta hydroxybutyrate values, because that is the most acidic ketone body. So if all these data are given, then I will say that, okay, I'm dealing with the case of diabetic ketoacidosis. Now, suppose they give you a question in the paper in which I'll use a different color pen for introducing the contrast. The question will begin by saying that the pH is 7.3. The PCO2 of the patient is 30. The guy is hyperventilating. Bicarbonate is 15. So everything is like turning out to be metabolic acidosis once again. But just to give a twist to the question, he says ketones are absent. Can't be diabetic ketoacidosis. No, you need a D, you need a K, and you need a A. I mean, the acidosis part is there. Diabetes, I'm writing because random blood sugar is 300 with symptoms. The guy is unconscious. But this is unlikely to be diabetic ketoacidosis primarily because ketones are not there. So to be sure about my diagnosis, I will obviously write beta hydroxybutyrate levels. But apart from this, I will also be writing one more test for this patient, that is serum lactate. And if this turns out to be elevated, then I will say that the person is having lactic acidosis. Yes, diabetic patients can be having two types of acidosis. One can be diabetic, second can be lactic acidosis. The reason for this lactic acidosis is most of the time that the patient was being given metformin. Metformin is absolutely contraindicated if the estimated glomerular filtration rate. Remember, this is a very important statement that I'm making before you. Metformin, this is medical legal negligence, guys. Otherwise, a patient will sue the doctor. The doctor will surely lose the case. Metformin is contraindicated if the estimated GFR of the patient is less than 30 ml per minute, 1.73 meter square of body surface area. And like this complication that has been asked in the exam related to this is lactic acidosis. I'll emphasize the statement once again. One, to be sure about lactic acidosis, I need to do serum lactate levels, understandably. But then usually this is occurring because of two reasons. Either it can be sepsis. Sepsis also causes lactate levels to be elevated, but then there the person would be in intensive care unit. He might be having a pneumonia, UTI, pyelonephritis, some evidence of infection will be there. If the person is not having any evidence of infection and still there's a lactic acidosis, then it could be because the person is having a iatrogenically induced lactic acidosis, because metformin was given to this patient though the eGFR was low, because when eGFR is low, body cannot excrete lactic acid and lactic acidosis can be triggered. Now, coming to the next question, here my students reported that boss pH was normal. The PCO2 was also very decent. Bicarbonate value was also decent. So everything is normal. Now pH is 7.35 to 7.45. PCO2 is 35 to 45. Here it is 40. Bicarbonate was 22 to 26. Normal values you are anyway familiar with, but I'm still writing for the sake of it, like 35 to 45 millimeter of mercury. When it comes to the bicarbonate values, it is in milliculars. pH is 7.35 to 7.45. I don't need to write it. Everything was normal. Then he did mention ketones were like 1 plus or 2 plus. Okay, I mean, guy could be starving. That's why ketones can be there. But the blood sugar was ultra high, 600 milligram. All values are being described in milligram deciliter. So the values are very, very concentrated. And the special test I can do in this patient is plasma osmolality. And because the sugar in the blood is very high, the plasma osmolality is very high. So high plasma osmolality is removing water from the neurons. It's removing water from the cells, and therefore there's an intraneuronal and an intra-body dehydration. Water is being removed from the cells. There's an intracellular dehydration which is present, neuronal dehydration. This is present. This presentation is called as hyperglycemic hyperosmolar state. In hyperglycemic hyperosmolar, the word is hyperosmolar state. I did a special investigation by the name of serum osmolality. Normal plasma osmolality is in the range of 275 to 295 milliosmoles. I'll write this value. Plasma osmolality in a normal person is in a range of 275 to 295 milliosmoles. In this question, the values would be given in range of about 300, 310. So you get the word hyperosmolar coma or hyperosmolar state in a patient. And now I'll mention a patient in whom, like the examiner said, that pH was normal, PCO2 was normal, bicarbonate was normal, ketones were negative. Random blood sugar of the patient was, let me say, 150. You can see that at this value 150, it is unlikely that, I mean, diabetic 150 is not a very dangerous value. I'm not saying sugar is low. If it was like 20, 30, I'll say hypoglycemia, but it is euglycemia. pH is normal, PCO2 is normal, bicarbonate is normal, urine ketones are negative. I mean, they're negative in normal person. The random blood sugar is like 150. He gave this report and he said that what is the next investigation that you will be doing in this patient? So I will be suspecting CNS event like stroke. Because if metabolic problem is not there, then there could be a CNS problem. So I'll be doing a CT head in this patient, because what I'm suspecting in this patient is a cerebrovascular accident. What I'm suspecting in this patient is a possibility of stroke. So what I've done here in front of you is given you various permutation combinations with respect to unconscious, unresponsive diabetic patient, diabetic ketoacidosis, lactic acidosis, hyperosmolar coma, and then a query stroke, with special mention to the investigations that can be given in a question or can be asked to you. Now, how do we give insulin to the patient? Well, there are multiple ways. One of the best ways to give insulin to anybody is via insulin pump. Now, insulin pump, like in English, it's an insulin pump, but for us doctors, the technical word is CSII. You can see a small Teflon catheter through which you are delivering insulin onto the abdominal wall. This is CGM. This device that you can see here is a CGM, continuous glucose monitor. And based on the sugar values current, we are delivering insulin to the body. And in case the sensor measures that the sugar values are dropping, then it will by itself, by default, stop giving insulin to the patient. So in continuous subcutaneous insulin infusion, like it's an automated system. You can connect it to artificial intelligence via SIM card, via internet connection, and then like it can regulate. The AI can be regulating the delivery of insulin to a patient without any intervention of any doctor. So continuous subcutaneous insulin infusion is the most effective method of delivery of insulin, because you don't need to calculate how much is to be given. If somebody's sugar is dropping, then the system by itself will turn off and will stop delivering insulin to the patient. Now, obviously, the insulin pump will be expensive and is put on the anter-abdominal wall. So, a lot of Indian patients may not be having that financial power to purchase it. So, they can be using insulin pen. Insulin injection is always given on the anter-abdominal wall. The needle of this is very, very thin, so it will hardly be a painless or a bloodless delivery of insulin. When you give this injection, the injection of insulin is always given at 90-degree angle to the skin. Though I'm saying the word subcutaneous, the point is that this injection would be given to the patient at 90-degree angle. The injection that would be given is at 90-degree angle to the skin. Then some people are very afraid of injections, so we can be using inhaled insulin also. The inhaled insulin is what is called as Afrezza as a brand. It would be having rapid acting insulin, and the advantage is that it can be taken before meal, it can be carried in a flight, and if a patient is like traveling and he is having his meal in flight, so there's no need of like taking injection in front of everybody, just a quick puff. And then obviously most Indian patients will not have purchasing power for all of this. So what they will be doing is they'll be purchasing this multi-dose vial of insulin. You can see multi-dose vial of insulin. Along with this multi-dose vial, 1 ml of insulin syringe would also be used. You need to teach them calibrations because overdosage or underdosage of insulin can be given. But these are the common, like, I can say methods of insulin administration. At this moment, I can also mention 3 questions. What is the preferred site? What is the preferred route of insulin administration? Specifically with respect to the site, if he says, what is the preferred site? Your answer is anterior abdominal wall. If he says where in the anterior abdominal wall, it will be 2 centimeter away from the umbilicus. We don't give the injection exactly at the umbilicus. It is 2 centimeter away. It is 2 centimeter away from the umbilicus where like the insulin will be delivered. The route of administration is obviously subcutaneous. The route of administration is obviously subcutaneous at 90-degree angle to the skin. Vaccines, the needle is long now. So that is why, like I was saying, that the vaccine part, like the injection would be given at an angle of 45 degrees to the skin. But when it comes to the preferred site, the preferred route, then the answers are anterior abdominal wall. The route is subcutaneous. If he says what is the preferred method, then I've already explained to you that would be called as insulin pump in English. The technical word is CSII, continuous subcutaneous insulin infusion. Can you tell me which insulin is long-acting weekly insulin? Like which form of insulin are you aware that can be acting for 24 hours? Can be working for 24/7, that is 168 hours. I repeat my question, like Glargine is working for 24 hours. That will never be a challenge for you. I mean, Glargine came so many years ago, so everybody knows about Lantus and Glargine. I said, which form of insulin are you aware of that can be given in the form of weekly injections to a patient? Then long-acting weekly insulin can be given to a patient, that is in the form of Icodec. It is ICODEC, Icodec, which can be given in a weekly format to the patient. Then is start insulin. When should you start insulin? Then asymptomatic patient, type 2 diabetes, HbA1c more than 10% is the usual indication. Values between 8 to 9% we will be managing with oral hypoglycemic agents. If there's a symptomatic type 2, this was asymptomatic. If the person is symptomatic and is having a catabolic process occurring in the body, then the threshold is 9%. I repeat my statement. If the value in an asymptomatic newly diagnosed patient is between 8 to 10%, oral hypoglycemic drugs equal to or more than 10%, it is insulin. Otherwise, the cutoff is 9% for a symptomatic patient with a weight loss. So that's like the usual indications when you would be starting insulin in a patient. Apart from this, start insulin if the patient is having emergency scenarios. Emergency scenarios could be in the form of diabetic ketoacidosis. Then in the earlier part of the discussion, we have handled diabetic ketoacidosis, then is hyperosmolar coma. Then another reason can be acute onset hyperkalemia, because insulin causes potassium to go inside the cells. So though this is discussed separately even in the kidney section, that we shall be using calcium gluconate for management of hyperkalemia initially, but calcium gluconate will not cause potassium to go inside the cells. So if you want potassium to go inside the cells, you have to give insulin drip for the person. So what I mentioned is standard routine usages when insulin would be required. Obviously, like for intensive control we need it, but then in emergencies the type of insulin that would be used is regular insulin. In all the 3 varieties that I have mentioned, it is preferably regular insulin that would be used. Then is Somogai phenomenon. Somogai phenomenon is the side effect of insulin administration. If you give more insulin at night, then the blood sugar will begin to fall. So Somogai has an alphabet O, and from that O you need to remember that there is a nocturnal hypoglycemia. There's a nocturnal hypoglycemia developing in this patient. The logic is if you give like extra insulin, then sugar will begin to drop. And when the sugar will begin to drop, then there will be production of counter-regulatory hormones. Obviously, like if your sugar will begin to drop, then the pancreas will start producing glucagon. Insulin production will begin to stop as the sugar values will plummet to less than 70. The production of insulin will stop and glucagon production will start. Apart from glucagon, other hormones can be like cortisol, then catecholamines, growth hormone. All of them will start increasing the sugar values. I'll just write the name of the counter-regulatory hormones from physiology that you're familiar with. If sugar of yours and mine begins to fall, glucagon will be released, cortisol will be released, catecholamines will be released, growth hormone will be released. So due to the release of counter-regulatory hormones, when you will check the pre-breakfast blood sugar of this patient, then at 7 a.m. or 8 a.m. the sugar will again be very, very high. Why is it high? Because it took lot of insulin at night and therefore there was a drop and then there was a rise. If I draw a graph like this, I can say sugar of this patient was crashing at night, then these hormones came to rescue and the sugar values will be higher than what is the euglycemic range. When you give insulin, you want a euglycemic range, but here the sugar is rising. Like at 4 a.m. in the morning, the sugar is dropping, and maybe at 7 a.m. in the morning, the sugar values are elevated. To see you got me or not, give me a feedback, right? Give me a feedback here. If in this particular patient, the sugar at 7 a.m. is suppose highly elevated, what would you like to do? Would you like to increase the morning dose of insulin first? Or would you first like to check how much insulin was given last night? Obviously, one option is I can increase the dose of insulin in the morning because morning sugar is elevated, but it does not make sense because the trigger was more insulin at bedtime. So first we should regulate whatever is the insulin at bedtime, and this can be like, usually a cause for pre-breakfast hyperglycemia occurring in a patient. So adjust the nighttime dose before you try to give morning dose to the patient. But let's talk about dawn phenomenon. Dawn phenomenon is something that we encounter only with respect to type 2 diabetes. Dawn phenomenon is like seen with respect to type 2 diabetes mellitus, where the sugar values will spike between 4 a.m. to 7 a.m. in the morning. So at night, the sugar values in these patients can be normal, or if you take the sample at a little after 4 a.m., sometimes the nurse might sleep and she might wake up at 4:15, though you had asked her to wake up at 4. I mean, you yourself decided to take a sample in the night, but you got up a little late. So you might get a euglycemia, or there might be a slight increase in the value if you take a sample, let me say beyond 4 o'clock. But in spite of all this, like in this person, the main problem is growth hormone peak between 4 a.m. to 7 a.m., which will contribute to pre-breakfast hyperglycemia. So for this person, max you can do is just increase the morning dose of insulin so that you don't have ill effects of elevated sugar on the tissues, because sugar elevated is always a problem. What I wanted to bring to your attention is that Somogyi phenomenon has an alphabet O present. So as such, I don't think so somebody should have an issue in remembering that the sugar at like 4 o'clock in the night is beginning to crash. But in dawn phenomenon, the sugar values will be normal to slightly elevated, and then pre-breakfast hyperglycemia is a common thing. See, he will not ask you regarding pre-breakfast hyperglycemia because dono mein hi it's a elevated sugar. It is rather the hypo component of Somogyi that is asked, and just need to adjust the night dose in the patient. As far as the basal bolus regimen is concerned, this is taught in pediatrics, but I'll just throw my bits here. For basal insulin, we are supposed to use long-acting insulin. Long-acting insulin would be like glargine, which will be working for almost like 24 hours. So the 10 p.m. insulin, the bedtime insulin is what I'm talking about. Whether he says in the MCQ the word bedtime insulin, whether he says 10 p.m. insulin, whether he says basal insulin, your mind should immediately click he's talking about glargine. I say that again, bedtime insulin, 10 p.m. insulin, basal insulin, it is always glargine. It will work for whole 24 hours. Like this particular person, last night I had given insulin to the patient that was glargine. So the values of glargine will remain like this all through till the next 10 p.m. Till next 10 p.m. in the night. But when this patient will go and have his breakfast in the morning, then before taking breakfast, I will be telling this guy to take a shot of insulin. It is 15 to 20 minutes ago. That would be a rapid acting insulin, that is bolus insulin. So bolus is what is given. The arrows here mean bolus before a meal. Like suppose somebody is eating at 10 o'clock in the morning. So I'll tell him at 9:45. It's a child going to school. He's eating breakfast at 6 a.m. in the morning. So insulin should be taken at 5:45. So just a few minutes before, how much minutes before? Something like 15 minutes before, we can be giving insulin to the patient, which is like before breakfast, before lunch and before dinner insulin. This insulin is called as bolus insulin because it is given before meals. This insulin is called as bolus insulin. It is to control the postprandial spike of sugar that would be happening in a diabetic, to bring the sugar values to respectable levels. It is before meals. That what type of insulin would be given? Your answer would be rapid acting. Rapid acting would be like Lispro, Aspart, Glulicin. So any of these molecules can be used. The common ones that I'll write at the moment are Lispro. We can give Aspart. All of these, these are all made by DNA recombinant technology. And we just tweak, like normal insulin has 51 amino acids. So we just tweak the chemical structure of it. The names are Lispro, then is Aspart, then is Glulicin. These are rapid acting insulins. They start acting within 10 to 15 minutes, and they act for something like almost about, the duration of action is short. Basically max they'll be acting for like 4 to 5 hours, but like the action starts very fast, so that's why they have to be taken before meals. The point is basal bolus insulin. Basal is the black curve that I showed, and like the bolus shot is like right before the meals, the rapid acting format. So most patients of type 1 diabetes might be requiring like 4 injections in a day, though some patients will ask you to or request you for like 2 shots also. So you can combine the short acting with intermediate acting insulin, or you can combine the rapid acting with intermediate acting insulin. Glargine cannot be combined with anything. Glargine, I told you, it will act for 24 hours. Glargine is the blood time insulin. It will work for 24 hours. Then we had insulin that needs to be taken 3 times per week. That is going to be Degludec. Degludec works for 42 hours. And now we have a third format that is called as Ecodec, which I said is 24/7. So this will be working for good 7 days. Let me just put in the data. Like I spoke about long acting insulin, then I talked about insulin which is even more long acting, going up to 42 hours, and now I'm talking about ultra long acting insulin. Instead of writing in hours, that would be 168. 24/7, 168, I'm writing 7 days. So these are like those long acting formats that can be used, and gradually we are shifting from short acting molecules to long acting molecules. Once a week is always convenient, and people prefer to take that treatment also. Then for the skin involvement in type 1 diabetes, very easy. Before I get into that, I just want to touch upon this topic again. Diabetes with chronic kidney disease, it is SGLT2 inhibitor. Diabetes with heart failure, again, I want to get a cardiorenal benefit, but if it is previous MI or atherosclerotic cardiovascular disease, then answer is GLP-1 receptor agonist, that is like semaglutide, which is to be given to the patient. As far as the skin manifestations are concerned, the most common skin manifestation in type 2 diabetes mellitus is not to be answered as acanthosis nigricans. This is one of the commonest mistakes the students make, that they end up, this is again a common error, guys. In fact, like I would rate this as a common error again, that this is not gonna be answered by you as acanthosis nigricans. The casual word for this would be blinky spots. If you have a diabetic in your family, you will notice that on the shin, they would be having some brown color macules present. So the most common one is what you can see at the moment. This is diabetic dermopathy, that you can see the brown color macules that I'm talking about. And it is not that velvety black pigmentation that you get with acanthosis nigricans. I'll come back to the diagrams, but just going back to the theory, the most common skin lesion that you see in type 2 diabetes mellitus is diabetic dermopathy. The alternative name for this is blinky spots, and they would be brownish macules on the shin of the patient. If I change my question to type 1 diabetes, then the lesion will again change. For type 1, let me show you the image now. You will notice central flaring. Like if you look at the yellow part here, there's some central flaring. It looks like a lesion in the periphery with a bit of scaling in the periphery. So where I put the star and the tick mark, this is the lesion that I'm talking about. This has a very peculiar name. If you read it once, it is very unlikely to ever forget in your life. It is called as necrobiosis lipidoica diabeticorum. This is commonly seen in type 1 diabetes, and especially in girls with type 1 diabetes. Gender, however, is not to be remembered. What is more to be remembered is the word necrobiosis lipidoica diabeticorum. Necrobiosis lipidoica diabeticorum is the name for the lesion on the shin of a person of type 1 diabetes. Then is a question saying, what is the most common skin lesion in a glucagonoma? In glucagonoma, look at how the question was given. He mentioned patient was having deep vein thrombosis episodes, recurrent ones. Then he said patient is having depression. Then he said patient is having diabetes mellitus. Diabetes mellitus was mentioned as like fasting sugar more than 126, 2-hour values more than 200. So it was a couple of D's that were given, that is DVT, depression, and diabetes. And then he said, what is the skin lesion that is present here? So normally we read about these with respect to that, corn eater, and with pellagra we read diarrhea, dermatitis, and death in a patient, or diarrhea, dermatitis, and dementia. But here I'm not talking about any like diarrhea, dermatitis, dementia. I'm talking about deep vein thrombosis. Let me just rephrase the alphabet V there. I'm talking about DVT, that is deep vein thrombosis. Then is depression, that is diabetes mellitus. This is what is seen with glucagonoma, because glucagon will cause fasting blood sugar to be more than 126, 2R values to be more than 200. So diabetes with along these two facts. And then there's a dermopathy also that I'm asking you actually. So I just gave a lag period of 15 minutes making you think that if you have read about this in derma, and the derma teacher has discussed it. I've seen by myself, all platform derma teachers love to discuss about this fact as some, they always like would be excited as extra knowledge pack, right? But for this is routine. Okay, so the most common skin lesion in glucagonoma would be called as necrolytic erythema. Yes guys, this would be necrolytic migratory erythema, not to be mixed up with that superficial migratory thrombophlebitis that we read with lung cancer. Not to be mixed with superficial migratory thrombophlebitis. This is necrolytic migratory erythema, guys. This is a high-yield topic that is being discussed. Diabetic dermopathy is less studied by us, and that's why they put up these questions. The causes of acanthosis nigricans are also to be remembered. Like insulin resistance is obviously standard. Insulin resistance can be seen in PCOD. Insulin resistance can be seen in type 2 diabetes mellitus. In your exam, NEET PG, neither PCOD, neither type 2 diabetes was given. Without looking at the notes, tell me what causes acanthosis nigricans. Obviously, you can pick up the hyperpigmentation at the dorsum or the neck of the person, but apart from the causes of insulin resistance that I've written, PCOD, type 2 diabetes, anywhere else do you read it? Yes, you read it with respect to metabolic syndrome. Metabolic syndrome is also called as syndrome X. Metabolic syndrome is also called as syndrome X. The details of metabolic syndrome are given in the endocrine, are mentioned in the cardiovascular system part. I'll say it verbally. The blood sugar will be more, weight will be more, BP will be more, lipids, triglycerides will be more, and HDL, good cholesterol, will be lesser. That's metabolic syndrome. The fourth aspect which I want to say is that this could also be a manifestation of internal malignancy. I mean, acanthosis nigricans can be seen as a skin manifestation related to pancreatic cancer. It can be seen with respect to colorectal cancer. So these are the, the aspects of acanthosis nigricans 3 and 4 which are to be given the due respect. And then diabetic patients can be developing on the sole of the foot a non-healing ulcer. The most common site of non-healing ulcer in a diabetic patient will be, however, on the toes. It can occur on the metatarsal heads also, but diabetic patients are advised not to walk bare feet. They can develop a non-healing ulcer on the sole of the foot. The ulcer would also be called as neuropathic ulcer. The three common sites where a neuropathic ulcer can be present is because when we stand on our foot, the weight of our body will be falling on the toes, and then it will be falling on the metatarsal heads. That's where the non-healing ulcer is present. The reason for this non-healing ulcer is that angiopathy will happen. The blood supply becomes lesser because diabetes affects small blood vessels. So angiopathy will mean that the fibroblastic activity in the repair process would be slow. So metatarsal heads, and then can be present on the heel as well. The image, the one which I'm putting at the moment, this is necrobiosis lipidoica diabeticorum. I use a short form for it. Then you can see the blinky spots, which are like the brownish macules that I was describing of diabetic dermopathy. And then the lesion is that unmistakable one of that of acanthosis nigricans. So from the skin perspective, like identifying the lesion is not important, but then like I mentioned a couple of technical domains also, like necrobiosis lipidoica diabeticorum, NLD, which is shown here, or blinky spots, or like association of acanthosis nigricans with colorectal cancer or pancreatic cancer or GI cancers, which is to be remembered. So this slide is, I would say, supplementary to the traditional information that we read with respect to diabetes. And diabetic nephropathy has been discussed separately, like the Kimmelstein, Wilson, and all those things are not discussed here because they've been discussed in the kidney section. So next up is the topic of pheochromocytoma. First, I'll talk about the histopathological finding. You can see these appearance of cells which look like to be present in nests. So you would be remembering from your pathology classes also that this appearance is called as nests of Zellbollen. The highlight of this tumor is also that it follows the rule of 10. But before I describe to you what is the rule of 10, let's look at some baseline information with respect to this tumor which is originating from the adrenal medulla. And one more miscellaneous fact I would like to say is that lots of time the MCQ might ask you association with, that would be neurofibromatosis 1. Now, if he just says to you that in a normal person, what is the major catecholamine that is produced, that's for you and me, then do not answer norepinephrine. Norepinephrine is what is majorly produced by pheochromocytoma because it's a tumor after all, so tumor will not respect physiology. So in a normal person, the major circulating catecholamine is epinephrine more than norepinephrine. But I can say 80% of pheochromocytomas are norepinephrine producing. So if he will specifically ask you about the tumor, then you will say that it is norepinephrine that is majorly produced. Then you will encounter a question on Sippel syndrome. Sippel syndrome is what I'll be discussing towards the end of this video, that is multiple endocrine neoplasia type 2. But if he specifically says pheochromocytoma associated with multiple endocrine neoplasia type 2 and he says what is the major catecholamine produced here, then the answer is again epinephrine. You can see that on listening to this information, the bias in anybody's mind can be that epinephrine is the major catecholamine produced. No, that is for normal people. And if it is pheochromocytoma associated with multiple endocrine neoplasia type 2, if general data is asked, then your answer is norepinephrine. As I said, 80% of these tumors are norepinephrine producing. Now, sometimes the tumor can be outside the adrenal gland. So the technical term that's used for this is called as paraganglioma. So if they ask you what is the major catecholamine produced by paraganglioma, the answer will still remain norepinephrine. Even if it's paraganglioma, the answer would still remain as norepinephrine. The neurofibromatosis association I've already mentioned. And before I describe the rule of two, I would like to say that because there is a tumor originating from the adrenal medulla, therefore the catecholamine surge in the body can cause this disorder to mimic, especially it can mimic anxiety neurosis, it can mimic panic attacks in a patient. So palpitations, headache, diaphoresis. I mean, lots of time the mnemonic that we used to remember the opening line of this MCQs, PHD, that is palpitations, headache and diaphoresis are the initial symptoms that can be experienced by these patients, and the catecholamines will cause a surge in BP. Now, because catecholamines have a short duration of action, because they have, in fact, of all the hormones that you will study in the entire endocrine system, norepinephrine has the shortest duration of action. So the BP will not be rising for a very long duration. You see, one is the rise of the BP, second is how long it is increased. So it can rise very high, but the duration for which it is rising will be relatively less. So I'm using the word labile hypertension. Or instead of saying the word labile hypertension, I can say episodic hypertension, that BP will rise for like few minutes, then it will come back to normal. Then again more catecholamine will be released. So again it will rise above normal, remain elevated for a short duration, come back to normal. So it keeps on fluctuating in an exaggerated fashion. Obviously in you and me also BP keeps on fluctuating. But here the rise and the spikes of the blood pressure would be like much more of what is normally present physiologically. So that's why I said labile hypertension, episodic hypertension. And then because catecholamines will also be contributing to, because catecholamines are counter-regulatory hormones, so they'll increase the blood sugar. So don't be surprised if you read fasting blood sugar more than 126, 2-hour values more than 200, impaired glucose tolerance can be given in this question, or just simply the fact that the person is having secondary diabetes, the reason for that being that catecholamines cause an increase of blood pressure. And next, what I will say is very, very shocking, postural hypotension. When I describe like this, the query of a lot of students is, sir, are you kidding me? Sir, you are telling me same patient is having hypertension also and hypotension also. Yes, guys, obviously not at the same thing. Either he can have hyper or he can have hypotension. In the early phase of the disease, you get hypertension. But in the later phase of the disease, you get exaggerated vasoconstriction. There is so much of vasoconstriction in the blood vessels that the total circulating fluid volume decreases, and therefore you could be having orthostatic hypotension and postural hypotension developing in the later stages of the disorder. There is no parallel to this anywhere else. Nowhere else will you ever read that hypertension in the initial phase of the disease, hypotension in the later part of the disease. So examiner is himself telling you that I am asking you pheochromocytoma by saying these words like episodic or labile hypertension in the initial phases of the disorder, and then in the later part of the same disease you get postural hypotension due to a severe extreme vasoconstriction. Now the most important MCQ on this topic will revolve around the screening and the investigation of choice. So I've touched upon it earlier, let's do it again. The screening test would be a urine test. So the screening test that we'll be doing in this case is a 24-hour urinary. Now the older test was VMA, vanillin mandelic acid levels, but now we don't use that test. In fact, currently the main test that is used for this condition would be a urinary fractionated metanephrine values. That's the name of the test to be remembered. And this is a good enough test. The only problem is that lots of patients, they may not be like ready to collect urine for 24-hour duration, saying unhygienic, religious reasons, whatever. How will I keep urine in the house when I have a temple in the house? So like that. So the investigational choice for this condition would be a blood test. I can do a plasma. This test should be done after the patient is lying supine for at least 30 minutes minimum. And like, because I don't want the patient to be stressed about anything, because if somebody is like afraid of needle, imagine there are some people who are like afraid of the hypodermic needle that we use for sampling. Even the fear will cause catecholamines to rise. No, so I don't want any bias. I want the patient to be relaxed. And then we go in for a plasma free metanephrine values. Why are we going for metanephrine? Why are we not going for like catecholamine? Estimation is primarily because of the fact that catecholamines have a short duration of action. So by the time we test the sample, they will be degraded in the sample. I repeat again, catecholamines have a short duration of action. So instead of checking for plasma catecholamine, though we have the capacity for testing them also, plasma catecholamines have a short duration of action. So it's a plasma free metanephrine that would be used for diagnosis. And once I've done this, then I will focus on the imaging modality for this condition. That is again an important question that has been asked umpteenth number of times. In fact, just to say that I would rate this statement of mine as the most important statement of pheochromocytoma. So I'm just using a different color to highlight this. Every time they've asked pheochromocytoma in the previous couple of years, they have mainly asked about gallium-68 DOTA-TATE PET CT scan. I mean, I don't know why, but the radiologists are seeming to take a lot of fancy for this question. So this is an oft-repeated question like gallium-68 DOTA-TATE PET CT scan is used for evaluation of. Answer is pheochromocytoma. And at this point of time, I want to say that this test is not only used for identification of pheochromocytoma, it is also the main imaging modality of choice for a pancreatic neuroendocrine tumor. So whether I say insulinoma, glucagonoma, somatostatinoma, VIPoma, any pancreatic neuroendocrine tumor, if they ask you, including for pheochromocytoma is obviously not a pancreatic neuroendocrine tumor, but I just divided this into two categories. Pheochromocytoma and pancreatic neuroendocrine tumor, the main testing is right in front of you. So first we go for biochemical evidence. That's the data in blue that I mentioned. Then we go for like tumor localization. That's the imaging modality that we are using. And then we have to go for surgery because treatment of choice for benign pheochromocytoma is a surgical resection. Now the issue is that before I do surgery, I need to stabilize the blood pressure of the patient. So he will ask you, what will you do for the management of preoperative hypertension in a pheochromocytoma? This is a repetition. I've already explained to you. We will be starting the patient on non-selective alpha blocker by the name of phenoxybenzamine. This will neutralize all the vasoconstriction that can be associated with this disorder. And I'll call the patient again after 1 week. Now, when he will come after 1 week, he will tell me that now my blood pressure is better, doctor, but I'm still having palpitations. I'm still having tremors because palpitations are related to beta 1. Tremors in the hands are related to beta 2. So what I will do next in this patient is I will introduce a second medicine by the name of propranolol. In these patients, first medicine to be introduced is a non-selective alpha blocker. Second one to be introduced is a non-selective beta blocker. And with a combination of these two, I'll be able to control major symptoms of the patient. And then later I can like send him again to an anesthesiologist for a pre-anesthetic checkup because the BP is under control, the heart rate is under control. So we would then be proceeding with surgery of this patient. I will also tell the patient to purchase the medicines and come back to me. I will tell him when you wake up in the morning, 6 o'clock, 7 o'clock, whenever you wake up, first take the medicine for hypertension, phenoxybenzamine. And after that, like after your breakfast, I would recommend you that after you had your breakfast, then you take the second tablet, that is propranolol. Patient will not understand alpha beta. So ideally we should write on the strip and explain to the patient. Now let us assume, don't note down, listen to my words. Let me say this patient did not understand anything that you said. It's a known case of pheochromocytoma. Already his blood pressure is elevated. When he woke up in the morning, he took a non-selective beta blocker. So if he will take a non-selective beta blocker, you see in our body, like let's say this is a blood vessel, then we have alpha receptors and beta receptors and they balance each other. Alpha causes vasoconstriction, beta causes vasodilation. The guy's BP is already more. If we will take propranolol as the first thing in the morning because you did not explain properly, the patient thought that you are a very big doctor and he should not question you at all. So he took PRPNL, means propranolol in short form. He took this propranolol tablet post break. He was supposed to take it post breakfast, but he had it at 7 a.m. in the morning. So the guy will basically block his vasodilation. If you block the vasodilation, you can see that the alpha activity in this patient will be unopposed, and rest you can do the talking. You guys tell me what will happen to the blood pressure of this patient. It will spike. So beta plus alpha is not to be done in this patient. I'll say once again, alpha plus beta is what is recommended. Beta plus alpha is not. In the exam, you'll not have all time to run any logic like this. So I just want you to remember what is the main problem of the patient. Hypertension, no? So to control the hypertension, we will first give alpha blocker to the patient. Though I've explained that with rationale, what I want you to remember finally is the following information, which is that what is the medical treatment of this patient from the preoperative perspective. It is alpha plus beta that would be recommended for these patients, and beta plus alpha is absolutely contraindicated. Now this explanation I will remove from here because it creates unnecessary load in the notes, and the notes should be clear and very precise. And then there's a twist in the question. He will ask you, how would you manage a malignant pheochromocytoma? In fact, a lot of these questions in the apps would be deliberately starting, they will describe everything that I said superiorly, but he will then very smartly say patient is having malignant pheochromocytoma. Malignant pheochromocytoma, we will not go for surgery. Sir, for benign pheochromocytoma, if he says what is the treatment that would be recommended, then we will go for surgery. Obviously, it's a laparoscopic surgery that would be done. It would be a unilateral adrenalectomy. But by SX, I just mean to say that I want to perform minimally invasive surgical procedure of a laparoscopic adrenalectomy to get rid of this tumor which is causing catecholamine excess. But the question will very smartly say the word malignant pheochromocytoma, in which surgery, SX means surgery, is contraindicated. You do not operate on a patient in whom the tumor has already begun to spread. Metastasis could be to the liver or to any distant organ in the body. So what will I use is MIBG. MIBG is methyl iodobenzyl guanidine. The iodo that I'm using here is iodine 125. Guys, a very surprising thing. I've taught you 123, 131, 132 with respect to the thyroid topic, but I'm teaching you iodine 125 today, not for management of any thyroid disorder, but rather for management of a malignant pheochromocytoma. So that is what the examiner wants to hear, that you are aware of the fact that iodine 125. In fact, before I highlight this statement, I want to give another example. If you go through your surgery notes, in carcinoma prostate also, there is a concept called as brachytherapy. If carcinoma prostate is spreading into the pelvis, and usually it goes by the Bateson plexus to the lumbosacral area. So in patient who is suffering from prostate cancer also, we use iodine 125. Yes, we put seeds of iodine 125 in the tumor, and that's gonna cause the tumor to be getting destroyed, because those seeds will then be producing radioactive rays, that is beta rays, and the tumor gets destroyed. So in the same spirit, like we use iodine 121 brachytherapy for management of carcinoma prostate, I want you to remember that we can also use it using MIBG. That's the delivery methodology by which radioactive iodine is delivered to the malignant pheochromocytoma. And along with that, obviously, because if it's gonna spread, so chemotherapy will also be used. I would also like to just make a passing reference to the rule of 10 with respect to the topic of pheochromocytoma. Though exactly some books dispute this also, that rule of 10 is not exactly true. Sometimes some parameters are 15% also, but it just gives you a bit of insight into the disease process. So 10% of these tumors can be malignant. And how do you differentiate whether it is benign and malignant? Gallium-68 dotated PET-CT will differentiate benign from malignant. It is not a biopsy. We will not do a biopsy in a pheochromocytoma. The needle will cause damage to the normal layers of the gland. We can have Addisonian crisis. So the best way to differentiate benign from malignant is gallium-68 dotated PET-CT. So it tells you about the tumor's presence, and it also tells you benign versus malignant. So 10% are malignant. 10% of these cases can be familial in basis, that is associated with multiple endocrine neoplasia type 2. This is because of the red proto-oncogene. So I'll describe MEN2 subsequently, but I'll just give you a heads up. This particular person initially would be having kidney stones. So I thought he's having kidney stones, which can occur normally also. But he told me at COVID time I had stones, then 23 I had stones, 25 I had stones, 26, 27. What's happening is every year he's having stone formation.
So the guy is coming to me and is saying, sir, why is this happening to me? So I told him, you are having I found out he is having a parathyroid adenoma because I checked his PTH levels and it was elevated, calcium was elevated. So he got a parathyroid adenoma resected. Then he developed a pheochromocytoma after 10 years. Then he developed medullary carcinothyroid. So I will give you a description of Sippel syndrome in the later part of the discussion again. But the same patient of pheochromocytoma can develop multiple endocrine tumors in his life. He says, why am I so unlucky? Why is God punishing me? Why is God giving me so many tumors in his life? I said, sir, there's a defective genes responsible for it. The gene responsible is Rett gene on chromosome number 10. I'm not writing the number of the chromosome at the moment because that will come up subsequently. But you can see that 10% associated with men or Sippel syndrome. And I also said that about I said the chromosome involved for multiple endocrine neoplasia also sits on chromosome number 10. Then 10% of these tumors are extraadrenal. If they're extraadrenal, where would they be located? That is in the sympathetic ganglia, because sympathetic ganglia have the same origin cell, chromaffin cell, from where the pheochromocytoma originates. So lots of time in multiple subjects, you might notice pheochromocytoma being written as chromaffinoma, that because the cell of origin is chromaffin cell, and chromaffin cell is present in the body in the sympathetic chain as well. So sometimes the tumor can be having a extra adrenal location. The last 10% rule is 10% of these cases can be bilateral. Of the 4 rules of 10 that I mentioned, minimum that I expect you to remember is the second and the third one. 10% association with MEN2 and 10% having an extraterrestrial location, for which the term used is paraganglioma. So these are a couple of important details for the topic of pheochromocytoma that I have currently handled. PhD will be the opening line of the question, and it can mimic anxiety and panic attacks. Yeah, sugar values can be elevated. Weight loss would be present in this patient. Okay, additional point added. Weight loss would be catecholamine excess. No, so weight loss with hypertension, with blood sugar getting elevated. A lot of these patients might actually come back to you and say, doctor, are you sure that you were telling me that I'm not having diabetes mellitus? See, because if you check out the sugar values here, the blood sugar of this guy is getting elevated, IGT plus BP is also getting elevated, weight. I mean, weight is decreasing. That happens in diabetes mellitus also. Now, I'll say this once again. You have a patient who came to you. He says, boss, I'm having weight loss. I said, okay, tell me others. I have a headache also. Somebody told me, some doctor checked my BP, it was very high. And now, doctor, my sugar is also getting elevated. So, I mean, if you look at only this much of the data, anybody would think that the guy is having metabolic syndrome. No, I mean, due to diabetes mellitus, there can be a weight loss, and then there would be hypertension, which could be coexistent due to atherosclerosis and impaired glucose tolerance. But then if you look at the remaining features which are present here, palpitations, headache, diaphoresis, and in the later part of the disease, postural hypotension, you require multiple consultations to be able to figure out these facts. But ultimately, when you realize that you're dealing with a tumor hiding deep inside in the adrenal medulla of the patient. Now we will focus on Cushing syndrome. First, I'll talk about general things like pseudo-Cushing syndrome, like a lot of time obese people, chronic alcoholism, depression can be contributing to it. Then you will say what is the earliest feature to develop in patients of Cushing syndrome and the most specific feature. So for the earliest feature, I want to say that the cortisol values in our body keep on fluctuating all the time. Like cortisol is released in our body in a pulsatile fashion. So the levels of this can vary from like morning to evening. The least values of cortisol in our body are seen at 12 o'clock in the night. In fact, I'll just draw a crude graph representing it, like cortisol levels keep on fluctuating in our body, and the least levels are at 12 o'clock in the night, and then when we wake up in the morning, the cortisol levels will tend to rise. This graph that I've currently made before you guys is for normal people like you and me. Like our cortisol levels, they keep on fluctuating the entire day, and 12 a.m. in the night is when we have the least value of cortisol. Now, somebody is having Cushing syndrome, then what will happen is that the values will obviously be elevated. The values would obviously be elevated, but you can notice that this nocturnal dip, like in you and me, like the values of cortisol should be dipping at 12 o'clock in the night. This dip is not happening in a person with hypercortisolism, that is Cushing syndrome. I repeat this again, you and me, cortisol production tends to have a diurnal variation, but in Cushing syndrome, the diurnal variation is lost. That is exactly the statement that I wanted to bring to your attention, that if he says what is the earliest feature that is seen in Cushing syndrome, we will talk about clinical features also, but I'm saying from the hormone perspective, what is the earliest feature? Your answer would be given as loss of diurnal variation of cortisol production, and the least values of this would be seen at 12 o'clock in the night. Loss of diurnal variation of cortisol production is one of the earliest manifestation. Then the question will change over to what is the most specific feature that is seen in these patients. Then the specific feature is what you can see on the tummy of this patient. This is a young female and she's having like that Cushing-White appearance with a lot of fat on the neck area, fat on the cheeks area. So like I can say chubby faces, or like there's a buffalo hump also present. But like the main thing is the most specific feature would be striae. These are gonna be purple to violet in color. Normally in pregnancy, you get pink striae. Here it is purple, and along with purple or violet that might be described there, like relatively more broad striae, like purple, violaceous more than 1 centimeter. He will not write more than 1 centimeter. He will say purple/violet broad striae on the anterabdominal wall. And all of these patients will be putting on very significant amount of weight. So the cortex, I would say the cortisol, which is increased in the body of these patients, that causes these dermal changes. I mean, skin changes are like one of the early manifestations that is seen in this condition. These patients usually have a very thin skin and there's a easy bruisability. But what stands out very characteristically, as you can see in the image, is this purple or violet color striae or broad striae. The meaning of the word broad is more than 1 centimeter size. In pregnancy, they're very, very small. Then on the back side of the neck of this patient, there can be a pad of fat, PAD, pad of fat, because cortisol promotes fat deposition in the central part of the body. When cortisol is more, there's more fat in the face area and the neck area, behind the neck, on the chest, on the tummy. So you will notice that very characteristic round appearance that will be coming in these patients. Another term that's used to describe this pad of fat on the back side of the neck is called as buffalo hump, though he says discourages to use that word because that will make the patient feel a little, embarrassed, buffalo hump word. So dorsocervical fat pad is a more appropriate term. The skin becomes very thin, the person will become very fat. In fact, most of these patients, they might be showing you their Instagram profile picture of, let me say, 2 years ago or 1 year ago. Patient was very thin and skinny, and now suddenly the patient has become very fat. So just symbolically try to show lemon on sticks appearance. The lemon part is why the lemon word is coming in is because the central part of the body is becoming very round. So you get a centripetal obesity developing in these patients. And the sticks part is because these patients would be having muscle wasting. You see, most of these patients, the sticks appearance is basically because you get proximal myopathy. So this young lady, she says she was very skinny and like she said, I did all the household chores. No, I used to get groceries from the market. I used to take care of my mom. I used to take care of my dad. I never took any lift. I always used to go up the stairs. Even if I'm carrying grocery of 5 kg, 10 kg, I used to carry it. Now she says, forget about carrying grocery, doctor. I cannot even climb stairs. So muscle weakness is present. That sticks appearance basically highlights what I have currently just singled out. The sticks appearance means that there is a proximal myopathy that is happening, that is muscles of the hip joint, muscles of the shoulder, and overall, you look at the arms and the legs of the patient, they'll be very thin. Like it's a very round person, but the arms and the legs of the patient will be very, very thin. And then because in this condition, there would be excess of cortisol, the cortisol will activate the epithelial sodium channel. So you can get a hypokalemic alkalosis. It's a very smart hormone. It not only causes increase in blood sugar. So a lot of these patients, when they come to you, they may say that I was feeling so weak. So I just got my blood sugar tested, doctor. I think I'm a diabetic. But I'm just writing IGT because cortisol is also a counter-regulatory hormone. Just like I was teaching you that catecholamine is a counter-regulatory hormone. Even this, cortisol, Cushing syndrome is a disease of hypercortisolism. Don't answer ACTH. It is cortisol that is in excess. It increases blood sugar, so IGT can be present. But along with that, we will get muscle weakness, we'll get muscle cramps due to hypokalemic alkalosis. And because this hormone can even activate the sex steroid receptor, so you could be having a woman presenting with hirsutism and oligomenorrhea. In fact, this can be the opening line of the question. He will deliberately begin by saying, woman comes with complaints of hirsutism, oligomenorrhea, because he wants you to think in terms of PCOD. PCOD is one of the important causes of like infertility in India, where a woman would be having hirsutism and oligomenorrhea. But now let me rephrase the statements again. Suppose I give you a question where the blue data and the yellow data is given together. Let me just zoom it in. What I'm saying is, if I give you a question in which in a patient hirsutism, oligomenorrhea is given, you will think in terms of PCOD. But does PCOD have hypokalemic alkalosis? No. So if you get a question in which you are getting a combo, in a sense that you're getting a hirsutism with oligomenorrhea also given and hypokalemic alkalosis, then it cannot be a presentation of PCOD. PCOD is only related to like DHEAS and sex steroid values being elevated. But if I add features with hirsutism of purple striae, centripetal obesity, lemanostics appearance. See, lemanostics and striae, if I add, it will be easy for you. What I want you to realize is that if you read a question which is having this information, which is currently being highlighted, then you have to think in terms of Cushing syndrome. Now, suppose if I remove the blue data, I just say woman came with hirsutism, oligomenorrhea, she's becoming very fat, then it's okay. I mean, I will first think in terms of PCOD. And because in this condition, ACTH levels are elevated, the increase in ACTH can cause hyperpigmentation of the knuckles and of the interphalangeal joints. The last time I've spoken about hyperpigmentation of the knuckles and IP joints is for patients of vitamin B12 deficiency. But today it is not a vitamin deficiency. It is because ACTH in the body is elevated, and ACTH in the human body behaves like melanocyte stimulating hormone. This was an FMG exam question, that ACTH can behave like which hormone to result in development of hyperpigmentation, though I think was a very easy question because he himself said hyperpigmentation. So ACTH behaves like melanocyte stimulating hormone because in Cushing syndrome, ACTH values can be elevated and thereby hyperpigmentation of the knuckles and IP joints can be present. Having said that, now let's look at the causes why Cushing syndrome would be developing. So the mnemonic for this is SOAP. SOAP would mean alphabet S would be for steroids, obviously, like you are giving steroids to somebody from outside, then this particular person, due to exogenous intake of steroids, cortisol values would be elevated. And along with the increase of the cortisol, by feedback mechanism in this person, the ACTH values will start getting suppressed. So they'll give you this combination and then say, okay, which fits the bill? Answer is exogenous steroids that we're giving to the patient. The next reason can be lung cancer. It can be oat cell cancer of the lung, which will be having an ectopic ACTH production. Now, because I said there is an ectopic, you see, I'm using the word ectopic because normally in our body, ACTH is produced in the pituitary, the anterior one. In this person, it's an ectopic ACTH production, so ACTH will rise. This ACTH that will rise will now cause more stimulation of the adrenal gland second layer, and therefore cortisol production will increase. So you can see that if he wants to give you oat cell cancer, then both arrows will be giving in same direction, and he will himself use the word ectopic. Now another cause I can mention at the moment is adrenal adenoma. Adrenal adenoma was mentioned by me earlier as a cause of ACTH independent Cushing syndrome. Let me just refresh your memory. Like let's say this is the adrenal gland, we have zona glomerulosa, fasciculata, reticularis. The outermost layer is glomerulosa, the second layer is fasciculata, the third layer is reticularis. So I am having a tumor which is originating from the second layer. Like here I am distorting the diagram to say that person is having a tumor in the second layer of the adrenal gland, which I will call as adrenal adenoma. And you know that zona fasciculata produces cortisol. So in this condition, cortisol values will rise because the second layer of the adrenal gland, that is zona fasciculata, is having a tumor and cortisol will rise. But now when cortisol will rise by feedback mechanism, the ACTH values in the body will begin to reduce. I want you to follow the sequence because in exam you will not have time. So listen to this carefully. In adrenal adenoma, the tumor is producing excess of cortisol. When more cortisol will be produced, then by feedback mechanism, the ACTH values will become lesser. If you're listening to me carefully, in the first report and in the third report, hormone-wise it is the same. Cortisol is high and ACTH is less, but the reasons are different. In the first cause, what is happening is that the patient is taking steroids from outside. So he will write the word exogenous cause. Exogenous means that from outside the cause is present and therefore cortisol is more, ACTH will be suppressed. But in adrenal adenoma, it's a tumor which is causing excess of ACTH, which is causing excess of cortisol, and by feedback ACTH will become lesser. So this manifestation, or like this data that I just explained to you, was touched upon even earlier when I said the word ACTH independent Cushing syndrome. ACTH independent because without ACTH cortisol is more. Listen to the next data with lot of care. I know you're listening to me with care, but this time extra care. Patient is having a pituitary adenoma. If a pituitary adenoma is the cause of ACTH, then you will notice that the report of the O and the P will match. Pituitary adenoma will be causing excess of ACTH production, which will cause more stimulation of the gland and the cortisol values will rise. You will notice that the report that I mentioned for the second point, that is O and P, is matching, and the report that I mentioned for the S and the A are matching. Let me just put pointers there. The report of S and A is matching, in which ACTH is becoming lesser. And in point number 2, that is oat cell cancer and pituitary adenoma, the report is the same. So how would we differentiate between the two? That we'll also discuss. But at the moment, I want to introduce more terminology here. This pituitary adenoma that I'm currently showing you is also referred in multiple choice questions by the examiner deliberately as the endogenous cause. I want you to get used to the vocabulary. If you ever read the word exogenous, let me just make you practice this here. If you ever read the word exogenous cause of Cushing syndrome, what should click in your mind is steroids and this image, that is steroids will be more and ACTH will be suppressed. If you ever read the word pituitary adenoma, what should click in your mind is endogenous cause from inside the body. So endogenous cause, and the description for pituitary adenoma has already been touched upon. It is also called as Cushing disease, and it is also called as ACTH dependent Cushing syndrome. The P component is called as ACTH dependent because you can see that ACTH is elevated. That is why cortisol is elevated. So we will call it ACTH dependent Cushing syndrome. But if you look at the third entry, cortisol is elevated, but ACTH is low. So we call it ACTH independent. Too much of terminology, I understand. I will simplify it even further before you. The minimum I expect you to know at the moment is, even if you say, sir, abhi hormone yaad nahi hua chalega, SOAP to yaad kar loge na. SOAP, steroids, oat cell cancer, adrenal adenoma, pituitary adenoma. That is step 1 for you. SOAP should be imprinted in your brain, and the remaining thing I'll make you remember, right? SOAP, oat cell cancer, adrenal adenoma, pituitary adenoma. Those are the core things. So steroids, oat cell cancer, adrenal adenoma, pituitary adenoma are the core things that you need to remember. Now, let's focus on the screening test. I'll come back to this hormonal fluctuations again. The screening test that is to be done for this condition. Super important MCQ. Screening test for this condition. Your answer would be, I will be doing first a 24-hour urinary cortisol values. The 24-hour urinary cortisol values in this patient will be usually double or triple of normal because if you look at any of the causes written here, it's cortisol more in the first cause, cortisol more in the second, third, fourth. Every time cortisol is elevated. So 24-hour urinary cortisol is elevated and is the initial test that we need to do. Now, if he says what is the investigational choice for this condition, then to be 100% sure about diagnosis, I will be going at 12 o'clock at the night to the bedside of the patient. Patient was very intrigued, sir. Doctor sahab, you come at 12 o'clock in the night. Normally doctors come in the round in the morning. Now let's 8 o'clock, 9 o'clock. You have come at 12 o'clock in the night to trouble me, doctor. Why? So said, I want to take your saliva sample. He's like, crazy, doctor, you have to take my thoop ka sample, saliva sample at 12 o'clock in the night. I said, yes. Salivary cortisol values will be taken in these patients, and this would be a midnight salivary cortisol. In fact, the main focus here is midnight. If I don't have the facility of checking the saliva, I mean, you need a good center for where salivary cortisol can be checked, then I can take a blood sample also. I can go for midnight plasma cortisol. You can see that why are we going for this test is because in a normal human being, the values of cortisol are least at 12 o'clock in the night. So midnight salivary cortisol, very easy to remember. Midnight salivary cortisol is the investigational choice for this condition. The mnemonic is SOAP. Now we focus on the third and the fourth cause, endogenous. Endogenous means that it is coming from inside the body. Pituitary adenoma versus ectopic. Ectopic would mean that it is lung cancer. So I'll compare all the causes. Like we'll first focus on the two yellows here. The yellows are endogenous and ectopic. Let me just make you practice here. Endogenous basically means pituitary adenoma. Ectopic means always a lung cancer. So we are focusing, we'll talk about adrenal adenoma also, but I'll focus on the two yellows at the moment. The question in your paper said, how will a doctor differentiate between the endogenous and the ectopic source? Well, the rationale for this would be, let me first give you the rationale and then I'll write down the name. In both of these conditions, the values of ACTH in the patient would be elevated. So let me give you the rationale, then we'll come and put in the data. You see, I have a patient in whom ACTH is elevated. I have another patient in whom ACTH is elevated. One of these patients is having a lung cancer. The lung cancer is in fact one of the most aggressive lung cancers, oat cell cancer. The second patient, however, is having a tumor in the pituitary due to which ACTH values of the body are elevated. So this is the initial baseline report of the patient. Baseline report is that in both of these patients, ACTH is super elevated. Now what I will do is, I will be performing a test in these patients by the name of high dose dexamethasone suppression test. It is written as high dose dexamethasone suppression test where we'll be giving like 2 milligram Dexona to this patient 6 hourly, total of 8 milligram would be given. Dose is not important. What I want you to just focus on the word is that I am trying to suppress the cortisol production. High dose dexamethasone suppression test is being done to suppress cortisol production. Now just think logically and tell me, can you suppress the lung cancer? Can you ever suppress the lung cancer by giving dexamethasone? Do you think lung cancer will respond to dexamethasone and will get suppressed by it? Will it get afraid of it? Lung cancer will say, who the hell are you, man? Why should I be afraid of you? The values of ACTH after giving Dexona tablets will not change. The ACTH values before giving dexamethasone tablet and after giving dexamethasone tablet will still remain elevated. Like suppose it is 10 times elevated, it will remain 10 times elevated. But pituitary can still be suppressed. Pituitary can still be suppressed partially. So what will happen in this particular case is that the values of ACTH, suppose it was elevated to 10 times the normal. Now by single arm showing it is elevated to 5 times the normal. So what I want to say is that when it comes to a case of lung cancer will be non-suppressible. You check out the ACTH values before and you check out the ACTH values after. There will be no changes in the values of ACTH. But when you focus on pituitary adenoma, I want you to appreciate pituitary adenoma. This is gonna be, because it's a part of human body, so it will be partially suppressible. That is the basic gist of this entire question. And believe me, this is not NEET PG. This was asked in FMG exam. He said high dose dexamethasone suppression test is used for, you can understand it is used for etiological diagnosis. It is not used for diagnosis. Diagnosis we have already made, 24-hour urinary cortisol, midnight salivary cortisol. If you have to differentiate between endogenous cause, what is the endogenous cause? Pituitary adenoma. What is the ectopic cause? Lung cancer. I'll repeat again, what is the endogenous cause? That's what you need to have in your mind. Endogenous cause would be a pituitary adenoma. Ectopic source is a lung cancer. So to differentiate between the two, the test that you'll be writing for the patient is high dose dexamethasone suppression test. I'll just put in this data once again for clarity in the slide. High dose. In the MCQ, low dose will also be given. Overnight dexamethasone will also be given. So what you have to select is high dose. Listen to the words here carefully. High dose dexamethasone suppression test can not suppress a lung cancer. I'll say that again. You cannot suppress a lung cancer, man, but you can suppress pituitary because pituitary is a part of the human body. Simple English word. आप lung cancer को नहीं दबा सकते, right? Lung cancer is like रियल बैडी जिसे बोलते हैं ना. आई मीन वो कहता है भाई मुझे डराओगे क्या, राइट? रियल बैडी. एंड लाइक pituitary is a part of the human body. Pituitary is lived with the body, so it has some sharam. Like some, it says, man, I've been a part of the body for so long. Itna gadari to nahi karenge na. So it will show up partial suppression. I'll say the words once again, guys. This has been asked 2 times in FMG exam. In one, he said that high dose dexamethasone suppression showed no suppression. What is the possible etiology? Answer is lung cancer, no suppression. If he says the word partial suppression, like there were 2 arrows initially, like I deliberately made 2 arrows initially, and then you can see I made 1 arrow only. So there's a partial suppression happening. So I've not written those words like no suppression, partial suppression, but I hope it's clear at this moment that why are you doing a high dose dexamethasone suppression test? It is for differentiating the 2 causes of Cushing syndrome. At this moment, also a very interesting slide. In fact, 2 slides, I am literally tempting to speak about them. They are causes of excess of ACTH production. Those are lung cancer and carcinoid tumor. In the exam, he labeled these slides as A and B. In the A slide, you can notice the classical salt and pepper. You can notice white areas and then the dark areas present. So this salt and pepper appearance is very, very characteristic for carcinoid tumor. This salt and pepper appearance is very characteristic for carcinoid tumor, whereas you can see very dark blue cells which are present for the second slide. Yes, I think I'll use a green so it will be better visible. You can see this side, the ciliated columnar epithelium. So it is lungs. And there are so many blue cells which are actively dividing here, and none of them is having a very clear nuclear, I would say, appearance present. So since he's asking me salt and pepper appearance in the slide A, then most students were able to relate to the fact that for slide B, it must be a lung cancer, and the lung cancer we're talking about is one of the most aggressive one, that is oat cell cancer. And you can also, like they said, we could also pick up this epithelium, lined ciliated columnar epithelium on one side in the lungs of the patient. So like what I can say at the moment is that when we are dealing with oat cell cancer of the lung, this would be developing and spreading through the airways. Okay, maybe the oat cell cancer word may not be visible, so I'll just use a different color to highlight this. And meanwhile, the data is, yeah, slightly better. I mean, oat cell cancer of the lung and the salt and pepper chromatin of carcinoid tumor have been discussed here separately. I would suggest you to check out these slides even from the pathological perspective. In fact, in the previous couple of minutes, you will notice I've taken care of 3 histopathological slides. One is the nest of Zellbolen for pheochromocytoma, very unmistakable and impossible to miss. Second is salt and pepper versus oat cell cancer. These are 2 causes where ACTH values would always be elevated, and these are ectopic causes. Both of these causes that I've currently explained to you, salt and pepper for carcinoid and oat cell cancer, both of them represent like an ectopic source present here, which is non-suppressible, does not respect physiology. Partial suppression is always what you see with respect to patients who are having like a pituitary adenoma. So these are like the details for, I mean, a single slide I can say at the moment covers the core aspects that you need to remember for Cushing syndrome. So whatever I've said on these slides, guys, this is for complete photographic memory. You cannot afford to miss single word. Like in the main videos, no, it is still possible that you say that, okay, I zoned out and like I zoned out for a while. In rapid revision, guys, there is no scope of zoning out. It has to be 100% retention rate at all points of time. Next up, I'll focus on a table that I've already spoken about. This is the 3rd time I'm talking about this, but still, I think it's important that I do give bits about it. ACTH independent Cushing syndrome. Whenever you read this, what should stick in your mind is one of the causes, which was an adrenal adenoma, and adrenal adenoma is present in the abdomen. So he will say, what is the next best investigation that you will do? You can see from the table itself, and I've told in theory earlier that I'll be doing a CT abdomen. But if he says the word ACTH dependent, then the first test to be done in the patient is a MRI pituitary. This MRI pituitary will show me a tumor, but sometimes there can be microadenoma present. So to make it technical, now what I'm saying next is exclusively for NEET PG and INISAT. If you're an FMG student, you can skip this and move on to the subsequent slide. That is the subsequent topic. But for NEET PG, you need to listen to this. MRI pituitary was normal because there was a microadenoma that could not be seen. So one option is I go for inferior petrosal sinus sampling, but patient may not agree for it. So a test I can do is called as CRS test. CRS test for corticotropin releasing hormone test. This CRS test, now imagine CRH being given to you and me, ACTH will rise. If somebody is having a microadenoma, CH rise will be more, na? I'll say this again. If you give corticotropin releasing hormone to you and me, then due to the stimulation part of the anterior pituitary, the ACTH will rise. But if somebody is having a microadenoma, then the rise will even be higher. So that is what happens there. More than 40% increment of the values of ACTH we see if there is a microadenoma present. So MRI pituitary will help you localize a macroadenoma producing excess of ACTH. But if it's a microadenoma, either you go for inferior petrosal sinus sampling, as I was saying earlier, super invasive, patient will not give consent. So what is the next best test to be remembered? CRS test. And after doing a CRS test, then the 3rd test that I'll be doing for my patient is high dose dexamethasone suppression test that I was talking about, where I give 2 mg Dexona 6 hourly for 2 days, and I will be able to suppress only a pituitary adenoma, that too partially. But when it comes to lung cancer, there would be no suppression present. That is why words written here are ectopic versus Cushing disease. You can see why are we doing a high dose dexamethasone suppression test. It is to differentiate between, right? This is what I said now. High dose dexamethasone suppression is done to differentiate between ectopic source versus an endogenous cause. And what is endogenous called as? That is called as Cushing's disease. So whatever I have said earlier, the same thing I've replicated the way it is given in the textbook so that you can understand the rationale about why it is being discussed. To finish the topic, lastly, I would like to speak about Nelson syndrome, which INISAT people are very fond of. INISAT people, I would say, they usually tend to ask topics which are towards the end of any topic, right? Like we are already fed up of reading all these details and we are already mentally fatigued by so much of data. And he will ask you the last lines, the 2-3 lines of the textbook, Nelson syndrome. Nelson syndrome क्या होता है? It is bilateral laterectomy was done. Like let's say patient is having bilateral lateral adenomas and we went for bilateral laterectomy, but I did not know that the patient is having a pituitary microadenoma. Now if you will remove bilateral adrenals, just think logically, अगर आपका दोनों adrenal glands निकाल दिया जाए, then the control over the pituitary will be lost. You see, bilateral adrenalectomy will cause loss of inhibitory control over the pituitary, and I did not know that this pituitary is already having a pituitary microadenoma present. So now this microadenoma will be producing more amount of ACTH. I repeat that again. We did a bilateral adelectomy. There is loss of inhibitory control over the pituitary. So therefore, what will happen is the pituitary will start producing ACTH in increased amounts, and because it's a microadenoma, it will produce it even more. Because the ACTH will be produced in excess now, because the control over the release of ACTH is gone. Therefore, this ACTH will behave like melanocyte stimulating hormone, and it will start causing that hyperpigmentation of the knuckles and the IP joints of the patient. Why patient on Nelson syndrome will come to you is because of cosmetic complaints. This patient had undergone a surgical procedure of bilateral adelectomy and now is coming to you with hyperpigmentation over the IP joints, hyperpigmentation over the knuckles. Earlier, I had mentioned that some patients of Cushing syndrome, especially with lung cancer, patients of Cushing syndrome with lung cancer can be having this kind of hyperpigmentation because ACTH is very high, ectopic ACTH. But now mentioning that after bilateral adelectomy also, this kind of presentation can be seen. So in Nelson syndrome, they will ask you only two things: why it occurs and what it causes. So for the why, I think you can see from the line diagram what is the cause of Nelson syndrome: bilateral adelectomy causing loss of inhibitory control. He will not ask you loss of inhibitory control. The statement in blue is what you need to remember. Nelson syndrome is caused by bilateral adelectomy done in a patient with pre-existing pituitary microadenoma. Now the control over the pituitary is gone, so now it will cause more and more and more and more release of ACTH. And what will it cause? Then the manifestation. There are only two questions here. What is the cause? What is the manifestation? The manifestation would be answered by you as hyperpigmentation of the IP joints and the knuckles of the patient. At this particular point of time, when it comes to hyperpigmentation, which is related to ACTH, I would like to mention conditions where we read about hyperpigmentation with relation to excess adrenocorticotropic hormone in the body. The first cause why we can be having hyperpigmentation due to increase of ACTH is Addison disease. Addison disease is the autoimmune condition in which the adrenal gland is destroyed, and because if the adrenal gland, just look at the English here, if due to autoimmunity the adrenal gland is destroyed, then the check control over the pituitary is lost and ACTH will rise and you will start getting hyperpigmentation. So Addison disease has presence of hyperpigmentation. The second time we will read about hyperpigmentation is with respect to Oat cell cancer of the lung or with respect to carcinoid tumor. The slides of both of them I've explained to you. So how will the examiner write these two conditions? He will not write it as Oat cell cancer and carcinoid tumor. He will write the word ectopic ACTH production. Every time you read this phrase ectopic, that means outside the natural site of production, then ectopic ACTH production, as the name suggests, will cause a rise in the values of ACTH. It will behave like melanocyte stimulating hormone, and because it behaves like MSH, that is why hyperpigmentation in the body would be seen. The third reason why we're getting hyperpigmentation at the moment is Nelson syndrome. So these are again very hardcore endocrine aspects that I've highlighted. Hyperpigmentation is seen in Addison disease, Oat cell cancer, Nelson syndrome. No need for mnemonic as logic. No, in Addison disease, gland is destroyed. In Nelson, gland is removed. Ultimately, check mechanism is lost in both of them. Whether I say autoimmunity or whether I say surgical removal of bilateral adrenal glands, the check mechanism is lost. ACTH values will spike and lung cancer is producing ACTH in turn. So these are a couple of situations where hyperpigmentation will be present. We don't get hyperpigmentation in Addisonian crisis. The crisis is an emergency. Now, within few days, we will not have hyperpigmentation, will take a long time to develop. So we will not be getting hyperpigmentation with respect to, I can say, the following manifestations. And additional point I just want to say, since I said Addison disease is autoimmune in etiology, the investigation of Addison disease has already been discussed in the earlier part of the discussion, that it begins with A. It is called as ACTH stimulation test. The other name for this is co-syntropin test. And remember, sodium and potassium always have an inverse relation whenever aldosterone is at rule. Like in Addison disease, aldosterone in the body will be less. So if aldosterone in the body will be less, there would be salt wasting. So this MCQ can always be solved because salt wasting would be present, and because sodium potassium have an inverse relation because of aldosterone. So all questions of Addison disease will always be by default having low sodium and high potassium in the body. Whenever you read about Addison disease, you always have to remember the data that I said. In contrast, Conn syndrome is a condition which I've told you is a tumor in the first layer of the gland. what is the investigational choice for endocrine test for, I mean, obviously I'll do a CT abdomen to pick up the tumor, but the investigational choice for Conn syndrome that I've explained to you earlier, remember one was a ratio, right? Aldosterone renin ratio. But then I was talking about a second test that is called a salt loading test or a saline infusion test. So saline infusion test will fail to suppress the production of aldosterone. The values of aldosterone in these patients will be super elevated. When he will say what will happen to the sodium values in the body of this patient, then don't answer elevated. You will say sodium in the body will be normal. Why normal? Because along with sodium, water will also come, because aldosterone gets both salt and water. So when salt and water will come, therefore the sodium concentration in the body of this patient, pure mathematics, total body sodium is more, but sodium divided by water, sodium is also more, water is also more, numerator is also more, denominator is also more. Maths coming into picture, sodium concentration is normal. They asked this in a recent INISET exam, what happens to sodium in Conn syndrome? Answer is normal. Lot of guys answered increase. I agree that aldosterone is more, it will bring in more salt in the body, but there's water also coming. That water will cause dilution, man. But along with that, obviously for the potassium part, no such surprises. Potassium would be normal. So what I've just done at the moment is made you repeat what we have already discussed, but this box that I've said, you should be able to mix this box in your own handwriting under 30 seconds. If you're both of them, guys, I'm not saying one of them, I'm saying both of them under 30 seconds. Do it, man, do it today. Addison and Conn syndrome, write it fast. The IOC for these patients, the electrolyte imbalances that I mentioned, and like if you're able to figure them out in a short, because in exams, sir, you don't have logic, right? Then you operate on remote memory. So this is the time when you build yourself up. Okay. Now coming to calcium metabolism, easier stuff present here. The manifestation that is present here is what is called as Trousseau sign. This is carpopedal spasm. The doctor has put a BP cuff in the arm of this lady, looks to be a lady. So when the BP cuff has been put in the arm of this lady, we are trying to cause irritability of the median nerve, and irritability of the median, the ulnar nerve, will result in development of carpopedal spasm to develop in this patient. The technical term that we use for this is called as Trousseau sign. Very, very classical. For hypocalcemia and tetany, then you will tap on the corners of the, you can tap at the anterior border of the parotid gland. When you tap on the anterior border, you can tap anywhere along the course of the facial, but first we tap at the anterior border of the parotid gland. In normal person, nothing will happen, but in this patient, when you tap on the anterior border of the parotid gland, there is contraction of the circumoral muscles. Like you can see the twitching of the face of the patient that is happening. So we will call it Chvostek sign. In Chvostek sign, what you can notice is that there is twitching of the circumoral muscles. Chvostek sign is that there is twitching of the corners of the face, that is circumoral muscles. And in this particular case, like which is the nerve that you are basically trying to irritate? It is the facial nerve, which is motor to the face. But in Trousseau sign, by applying the BP cuff, you are trying to elicit the irritability of the median as well as the ulnar nerve, which will characteristically cause this flexion at the metacarpophalangeal joint. Like some actions will be caused by the ulnar nerve, some actions would be caused by the median nerve. So both median as well as the ulnar nerve in this condition will get irritated, and that is why this peculiar manifestation of MCP flexion and a thumb spasm would be coming. The whole thing that I described before you is what is also called as Trousseau sign. Don't mix it with Trousseau syndrome. That's why I wrote it again. Trousseau sign is carpopedal spasm, for which image of the blood pressure cuff may or may not be visible. And both of these findings are indicating that the patient is having deficiency of calcium in the body. That is, calcium normal is about the range of 9 to 11 milligram per side. But here, if the value is less than 7, that means person is going into tetany and can die. The reason for death would be laryngospasm. Patient will not be able to speak. So you need to put an IV line and give 10% calcium gluconate. This is the second time that calcium gluconate has come in the discussion. Prior to this, it has been used for management of dangerous hyperkalemia in a patient where potassium values are very high. But for tetany also, we need to do the same thing. What is the leading cause of hypocalcemia? Then it is inadvertent removal of the parotid gland during total thyroidectomy. But then there can be a second cause. If this is not given, then answer is autoimmunity. Autoimmunity has been blamed in endocrine section for type 1 diabetes. Autoimmunity is responsible for Addison disease and now for hypoparathyroidism in a patient. For hypoparathyroidism, what will we do? If he says, how do you manage surgically induced hypoparathyroidism? Ideally, this should have never ever happened and we should have gone for a parathyroid reimplantation. But because parathyroid reimplantation was not done, what we can do in this patient is we can give subcutaneous injections of teriparatide, which is synthetically made PTH given to the patient, and this will help in like stabilizing the calcium values in a patient. Then remember my basic rule that calcium and phosphate always have a inverse relation. Just like I was teaching you, sodium and potassium have a inverse relation whenever aldosterone is coming to play. Calcium and phosphate have a inverse relation whenever PTH is at play. Let's jot down this information so that we can retain this. Sodium and potassium have an inverse relation whenever aldosterone is at play. Like if aldosterone is gonna be like less in the body, then sodium will be less and potassium will be elevated, vice versa. And similarly for calcium and phosphate, an inverse relation is to be remembered. Now, if a person is having primary hyperparathyroidism, then what is the reason for primary hyperparathyroidism? If I put it symbolically, I can say that there are 4 parathyroid glands in our body. The patient could be having a tumor in any one of these 4 glands. Patient would be having a tumor present here. So the leading cause of why this happens to be a parathyroid adenoma. Most of the time, this parathyroid adenoma would be like an inferior parathyroid adenoma. I'll repeat the data once again. What is the cause of primary hyperparathyroidism? Your answer is parathyroid adenoma. Now, what will this parathyroid adenoma do? PTH will remove calcium from the bones. PTH function is bone reabsorption. So when we'll remove calcium from the bones, the calcium will rise. And calcium and phosphate have an inverse relation. Technically, it is lost by the proximal tubule of the kidney, so phosphate will become less. And because bone turnover will be increased, then serum alkaline phosphatase values would be found to be elevated in primary hyperparathyroidism. Let's do a quick recap here. What is the reason for development of this? Then the mental image that you need to keep in your mind is that the person is suffering from a tumor in the parathyroid gland. The person is having a parathyroid adenoma. And this is like an inferior parathyroid adenoma, which is contributing to the following manifestations. Now, suppose a person is having chronic kidney disease. In chronic kidney disease, the synthesis of vitamin D3 by the kidney will be less. If vitamin D3 will be less, calcium will be less. And if calcium is less, then PTH in the body will begin to rise. All the changes that I wrote here before you in color black basically signify what is basic physiology. Let's do it again. Kidney produces vitamin D3. Vitamin D3 is less, so therefore calcium in the body will also be less. If calcium is less, it will cause a rise of PTH in the body, but because it is occurring after so many physiological changes, I will say that this is secondary hyperparathyroidism. So secondary hyperparathyroidism is caused by chronic kidney disease. Quick recap in 15 seconds, less production of vitamin D3, less calcium. So there is a secondary increase in PTH. And therefore, when you look at the lab report of this person, you will notice the following changes. Calcium in the body will be less because vitamin D is less. Calcium and phosphate have an inverse relation. Plus rationale also, CKD glomerulus is damaged, phosphate will not be excreted and bone turnover is more. So they will give you reports like this and they expect you to answer primary versus secondary hyperparathyroidism. For secondary, the cause is obviously CKD. For primary, the cause is parathyroid adenoma. Now I will write the report of hypoparathyroidism. In hypoparathyroidism, the reason why this happens, I'll use a different magenta color for this, autoimmunity. Hypoparathyroidism can either be surgical or it can be autoimmunity. I'll write the medical cause of it, autoimmune destruction. Now mentally visualize, if the gland is destroyed, then PTH will be less and calcium will also be less. Calcium and phosphate have an inverse relation. I said hypoparathyroidism, there would be less PTH, less bone reabsorption, so calcium will be less. Calcium and phosphate have an inverse relation, so arrows are going opposite. And in hypoparathyroidism, don't answer SAP to be reduced. SAP will never be reduced. SAP can either be normal or it can be increased. It's never reduced. The only medical disorder where serum alkaline phosphatase ever becomes lesser is a condition by the name of hypophosphatasia. Now this, if you can remember, okay, otherwise you can let it go. What I want you to remember is SAP is normal in hypoparathyroidism. So you can easily differentiate the report from that of secondary hyperparathyroidism where SAP was elevated because of increased bone turnover. Now he will say the word pseudo hypoparathyroidism. In this case, what is the word used is pseudo hypoparathyroidism. Why are they calling it pseudo is because in this condition, PTH production is normal, but the PTH receptor is defective. I would like to draw parallels of this condition with diabetes mellitus type 2. Like in diabetes mellitus type 2, insulin is there, but receptor is defective. Similarly, in pseudo hypoparathyroidism, PTH is there, but its receptor is defective. If the receptor of PTH is defective, you will notice that report will be same. PTH will not be able to act on the tissue, so calcium will be less. And calcium and phosphate have an inverse relation. If you check out the report, because it is same, that is why the name is pseudo hypoparathyroidism. Pseudo hypoparathyroidism is characterized by defective receptors of the parathyroid gland. Here you will ask, sir, why is that so? Why are the genes, why are the receptors not working? So there's a defective gene for this. That's called a GNAS gene. If you can remember the name, that is okay. But I want you to remember that the report of hypoparathyroidism and pseudo hypoparathyroidism will be identical. And to see that you've understood me or not, please give me a quick answer. I just want you to nod your head. Don't look, check out the notes. If you will give teriparatide to somebody with pseudo hypoparathyroidism, if you give teriparatide injection to somebody with pseudo hypoparathyroidism, will PTH be able to act on the receptor? Yes or a no? Obviously no. Receptor is defective due to different genes. In hypoparathyroidism, because there's a hormone deficiency, if I give PTH to the patient, things will improve. But in pseudo hypoparathyroidism, the report is the same. That is why we call it pseudo. And here there is no treatment possible from the hormone perspective, because if the receptor is defective, you can't be God and change the receptor, right? I mean, this is not a partial resistance like in type 2 diabetes, it's a full resistance. So unfortunately, in pseudo hypoparathyroidism, we don't have any treatment available. In pseudo hypoparathyroidism, we don't have any treatment available, but they expect you to be able to work out this table in the shortest possible time frame. And how to work this out is, remember, calcium phosphate having an inverse relation and sodium potassium having an inverse relation with respect to PTH and aldosterone respectively. At this moment, I've described deficiency of calcium in the body, that is like the tetany manifestations were coming up in a patient. Now I will talk about hyperparathyroidism primary once again. The question will be very easy because we will talk about stones, bones, mones, and psychic. I mean, I can say stones, bones, mones, and psychic. In fact, for the mones part, I can just change or modify a bit. For this particular part, I can say groaning. Why I'm saying groaning is because even constipation will happen in the patient, no? Because calcium, if it is excess, it causes spasm of the sphincters of the gut. So spasm of the sphincters of the gut would contribute to development of that groaning, पेट पकड़ के रो रहा है कि सर पेट में दर्द हो रहा है, because of the constipation component which is present here. So it is stones, bones, groans, 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 and psychic moans which are present because he's always having abdominal pain, sir. Primary hyperparathyroidism is super easy to identify. Why? Because person will be having increased calcium, so there would be renal colic. Renal colic will cause like spasmodic pain to come towards the umbilicus. Along with this, calcium will cause contraction of the sphincters of the intestine. So you will get very severe constipation. Two endocrine disorders where you always read about constipation is, one is hypothyroidism, where you read about constipation, and second, constipation is read in primary hyperparathyroidism. So renal colic and constipation are two reasons why these patients would initially come to you. And why this condition is dangerous is because when calcium values in the body, like normal calcium in the body is in the range of 9 to 11 milligram. Once it crosses the 13 milligram threshold, this guy is literally sitting on a time bomb. What I mean by sitting on a time bomb is that this person can end up with development of systolic cardiac arrest. Sir, hypercalcemia is not a joke. The person can die because of a systolic arrest of the heart. Just like potassium causes a diastolic arrest of the potassium, causes relaxation. So diastolic arrest, calcium causes systolic contraction of the heart. The person can die. Because PTH in this patient is very, very high. You can also notice on this particular side, if I'll use a white for this, on this particular side, you can notice there's the reabsorption of the phalanges that is also happening. So lots of time the MCQ might mention this phrase. Like orthopedics people always will tell this statement, subperiosteal reabsorption of the phalanges. If you look at the phalanges, especially on the radial side, there is a very significant concavity coming because the bone is getting reabsorbed due to the increased values of calcium. So subperiosteal reabsorption of the phalanges. Subperiosteal reabsorption of the phalanges is a good radiological finding that is given in the X-ray hand of patients of primary hyperparathyroidism. After telling you all this data, then he will say what is the imaging modality that is used for this patient. Again, a favorite question of our radiologists, like what is the imaging modality that would be used here? And you guys would be ready with the answer also without having a look at the notes. Yes, guys, what's the imaging modality? Your answer will be technetium-99. You see, all these nuclear scans are like the cutting edge technology that we have, that we are able to identify very small parathyroid tumor. So the imaging modality we can do is a SystIMB scan, that is our SystIMB technetium-99 SPECT-CT. We also will talk about SystIMB in cardiology section for like in a treadmill test, but at the moment it is SystIMB technetium-99. SPECT-CT is the imaging modality of choice to identify what? To identify a parathyroid adenoma. There are 4 parathyroid glands in our body. The tumor can be originating in any one of them, and most of the time it is the inferior parathyroid gland of the patient. If he says what is the leading cause of hypercalcemia in hospitalized patients, then don't answer whatever I've told you till now, that stones, bones, groans and psychic moans look very good to remember, but this is not the commonest cause of hypercalcemia. The leading cause of hypercalcemia in hospitalized patients is lung cancer, and lung cancer of the which variety? Then answer is not oat cell, it is squamous cell cancer of the lung. Looks very shocking but true, guys. Squamous cell cancer will produce PTHRP. What is PTHRP? It is parathormone related peptide. It is not PTH. It looks like PTH. It will remove calcium from the bones, and therefore the calcium values in the body of this patient will begin to spike. So parathyroid adenoma is not the number one cause of hypercalcemia. It is lung cancer, and that too a squamous cell cancer. Now, because calcium can be high and it can cause a systolic arrest of the heart, so I need to be aggressive. The management part is what I have already explained to you in the earlier part, but will be more descriptive this time. We will be giving normal saline as a fluid of choice for hypercalcemia. So to dilute the values of calcium from, let me say, 13.1 to 12.8, 12.7, I want to remain below the threshold of 13. Along with normal saline, I will also add furosemide. Furosemide is a loop diuretic. This loop diuretic will be added to lose the calcium from the body. So NS with furosemide would be given. Then I will be giving the drug of choice for management of this condition, that is bisphosphonates. Bisphosphonates will basically reduce the bone reabsorption because calcium is coming from the bone reabsorption. So what bisphosphonates, ibandronate is a bisphosphonate. So what it will do is it will inhibit the osteoclastic activity, because see, where is the calcium coming from? It's coming from the destruction of the bones, and bones are getting destroyed by osteoclast. So if you inhibit the osteoclastic activity in the patient, the levels of calcium will begin to stabilize. I will also be giving an antagonist hormone. Antagonist hormone of PTH is calcitonin. So calcitonin nasal spray will be given to this patient. The problem with this is usually tolerance. Tachyphylaxis comes very fast with calcitonin nasal spray. So that is why it is not the drug of choice. If tachyphylaxis or tolerance was not a problem, it would have become the drug of choice. But the drug of choice is ibandronate. It usually shows effect for a couple of days also, because this condition will not get controlled in like 1 or 2 days only. Then I can give monoclonal antibodies, the ones that are used in management of osteoporosis. They will also do the same thing, inhibit osteoclastic activity, denosumab. Then what we can do is we can give oral phosphate to the patient. Phosphate will chelate, though this will increase the risk of like stones in a patient, but I need to prevent cardiac arrest. So I'm ready to take, see, one is cardiac arrest, second is stone. I'll prevent cardiac arrest first. So oral phosphate can be given. And if I've tried everything that I've told you from point number 1 to point number 5, then I will have to handle the patient with hemodialysis. Guys, this is one condition which they always love to ask, that is hypercalcemic crisis, and therefore this is a super important topic. Additional drug that we can use for management of hypercalcemia, steroids. But where would you be using steroids? Like, which are examples of steroid responsive hypercalcemia? So the answer in this case is sarcoidosis. Sarcoidosis में जो granulomas होते हैं ना, they produce vitamin D3 and that causes calcium to increase. But if I will give steroids to the person of sarcoidosis, then these granulomas will resolve and the synthesis of vitamin D3 will also resolve. Sarcoidosis is a medical condition where we have presence of non-caseating granulomas. I've spoken about sarcoidosis even in the respiratory section, that it's a female, her X-ray showing up bilateral hilar lymphadenopathy. I've discussed the X-ray findings also. FMG exam students, check out the sarcoidosis and rheumatology in the end, like the staging, no, that X-ray staging they asked in your exam. So I've covered it in the later part, but at the moment the point is that non-caseating granulomas contain this enzyme by the name of 1-alpha hydroxylase, and this will cause synthesis of 125 dihydroxy, and therefore the calcium values will rise. But when I will give steroids, it will respond. So steroid responsive hypercalcemia is for sarcoidosis. Then steroids are also used in management of multiple myeloma. This is a hematological malignancy that I've discussed in the liver, GI and hemat section, where I've said the mnemonic CRAB. CRAB is for hypercalcemia, renal failure, anemia, bony lytic lesions. You can relate bony lytic lesions will cause hypercalcemia, and steroids are used in management of multiple myeloma. For drugs of multiple myeloma, I would like to remind you, we use lenalidomide, dexamethasone and bortezomib, but the main drug that I want to talk about today is Dexona. That would be useful for these patients. And the third reason where we use a steroid responsive hypercalcemia is like vitamin D intoxication. So these are three reasons, three conditions in which steroids like Dexona will be used for management of hypercalcemia. Very contrasting data, no? Suddenly, I changed gears, from ibandronate furosemide nasal spray. I changed gears to steroid-responsive hypercalcemia for sarcoidosis, multiple myeloma, and vitamin D intoxication. The last thing that we will study is multiple endocrine neoplasia. So for MEN1, it's related to menin gene and chromosome 11. Let's look at the problem. There are 3 P's here: pituitary adenoma, parathyroid adenoma, and a pancreatic neuroendocrine tumor by the name of Zollinger-Ellison syndrome. Guys, I said in the beginning, most common pancreatic neuroendocrine tumor is insulinoma, but in MEN1, your answer will not be given. In MEN1, your answer will not be given as insulinoma. It is Zollinger-Ellison syndrome, a very favorite questions of our examiner. What is the most common pancreatic neuroendocrine tumor? Overall, insulinoma. If he says the word MEN1, then answer is Zollinger-Ellison syndrome, and then this can be associated with carcinoid, and we don't need all the 3 P's. 2 out of 3 P's are sufficient for diagnosis. The condition is autosomal dominant. The chromosome involved in Werner syndrome, that is multiple endocrine neoplasia 1, is 11, and menin gene. Now, I want you to focus on these 2 guys. Pituitary adenoma, that is 1. Pituitary adenoma, that is 1. The second one is pancreatic neuroendocrine tumor. Like I want to say that there are 2 tumors at the moment. One of them is pituitary adenoma, and the second one is this pancreatic neuroendocrine tumor. Both of them will lose their position. Both of them will lose their position when the elections are being conducted for the second time. There are 3 guys with P alphabet who won the election 3 times, starting from the tube, the pituitary, top pituitary, then parathyroid, and then pancreas. The pituitary guy will lose election, the pancreas guy will lose election, and only parathyroid adenoma will retain its position. So when you check it out, second time parathyroid adenoma has won the election 2 times, but the guy on the top, pituitary, and the guy at the bottom, pancreatic, has lost the election. New guys are coming in: pheochromocytoma and medullary carcinoma thyroid. This is what is called as Sippel syndrome. In Sippel syndrome, the history will be like this guy when he was young, 20 years of age. I'll just write it and then erase it. At 20 years of age, he had a pheochromocytoma, underwent surgery. At 40 years of age, he started having kidney stones. It was found it is kidney stones due to parathyroid adenoma. At 60 years of age, he is developing a swelling in his neck. It is stony, hard in consistency. When workup was done, it was found to be a tumor. So what I want to say is, in different decades of life, this guy will be developing different tumors. So pheochromocytoma, parathyroid adenoma, medullary carcinoma of thyroid. It is PPM to be remembered instead of PPP. And this time the association is Hirschsprung's disease, where there is a failure of the neural crest migration. In NEET PG, they asked MEN3. In MEN3, this parathyroid adenoma will lose election. Remember, he won the election the first time. He won the election the second time, but this guy is not lucky. He will lose the election the next time. The pheochromocytoma and medullary carcinoma thyroid will carry over for the next term. It will be their second term. Pheochromocytoma, you can see I've written once again. So pheochromocytoma will be carried over in the next term. Medullary carcinoma thyroid will be carried over next term, but parathyroid adenoma will lose the election. For MEN3, there are a couple of M's which are to be remembered. One of the former American president, Abraham Lincoln, was having this disorder, that is MEN3, where he had marfanoid habitus, mucosal neuroma. Those are bumpy lips. That bumpy lips and bumpy tongue is mucosal neuromas. Then our cornea smooth. Our cornea does not have any bumps. There are medullated corneal nerve fibers and they can be megacolon. So there are 5 M's to be remembered. Now, parathyroid adenoma has lost the election. Now new guys are winning it, and the M's present are medullary carcinoma thyroid, that's carryover from Sippel syndrome, marfanoid habitus, that is arm span more than the height. In you and me, height is more than the arm span more. I'm not saying Marfan syndrome, marfanoid habitus. That is mucosal neuromas, medullary coordinated nerve fibers, and megacolon, which would be due to intestinal ganglioneuromatosis. The data in purple that I've written is exclusively for like NEET PG and INISET. If you're an FMG aspirant, you just need to remember the names present. They'll ask you details like, INISET exam, they'll go a little more deeper. They'll ask you carcinoid is associated with, Hirschsprung's is associated with, intestinal ganglioneuromatosis with megacolon is megacolon word is present. Megacolon word written, answer it as MEN3. And if he says the word Hirschsprung's disease, where you get A ganglionosis present, then you will answer as MEN2A, also called as Sippel. Nowadays, they don't use the word 2A and 2B. That's only for the old MCQs. It is 2. The word used is, I'll just clarify this. The word used is either 2 or the word used is 3. Those are the traditional terminologies that are used for this. And MEN4 is like combination of MEN1. 3 P's, let's practice. Pituitary adenoma, parathyroid adenoma, pancreatic adenoma by the name of Zollinger-Ellison syndrome, then it is associated with, what is it associated with? That is tumors of the adrenal gland, renal and reproductive tract tumors. We don't have association of this within MEN1. For MEN4, the gene is also different. It is called as CDKN1 and it's on chromosome 12. So if you look at the data also, the chromosomes would be 11, then is going to be 10, and then is going to be 12. And over and above this, the genes are also to be remembered, like MEN1, MEN, usually I don't find any errors in remembering that. Then for MEN4, CDKN1, people to remember. It is RET and RET for MEN3. So what I've seen people forgetting is what I'm highlighting at the moment, that it is codon 634 and it is codon 918 respectively, that you have to remember. The RET gene related to different codons is responsible for this multiple endocrine neoplasias, and we don't need all three to occur. It is 2 out of 3 that should be happening in a patient. So these are the technical details, guys, that you need to remember for this topic. So keep hammering, keep learning these facts, and yeah, I mean, you will become wiser as and when like you keep on learning and revising these facts. Thank you so much for your patience and hearing me out.